Right, I think in the interest of time, we do need to start because we have a very packed schedule. I'm very pleased to welcome our speakers from different parts of Africa, different parts of the world. So welcome everybody to this afternoon's webinar. It's part of the University of York's Black History Month. And today's webinar is Health Research in Africa, Listening and Learning and Building Truly Equitable Partnerships. So this webinar, thank you very much for joining, is part of a series of events hosted by the University of York throughout October to celebrate Black History Month, and presents an opportunity, a space to reflect and learn about Black history, the issues facing contemporary society on an international level, and the insights and aspirations and initiatives tackling racial inequality. There's more information about York's events on Black History Month on our web pages. And really today, what we're trying to challenge, trying to address is how research that York and our partners are involved in can better integrate Black history and lived experiences into research activity and partnerships. And challenging questions of what we mean by silencing knowledge in international research, and how this reflects neo-colonial attitudes. With our focus on health, we're particularly keen to explore how we can learn from health interventions and implementations in Africa, and the importance of recognizing different contexts, and why it is important to better understand our African collaborators, or I'd rather say our African partners' context, and how our engagement, our research convened through York can deliver benefits in return. This is also part of an attempt to address challenges around decolonizing research that are taking place within academia in the UK. And we will, hopefully through these discussions, critically review and appraise how York and the UK research sector more widely can make genuine and meaningful changes to its practices in order to build fair, respectful, and mutually beneficial partnerships with academic communities across Africa. And this fits very closely with the university's own strategic commitment around internationalism and being a university for the public good. So it's very much a requirement for us to reflect very critically on how we engage and what we mean by equitable partnerships. And as part of the decolonizing effort, we tend to speak quite generally about the colonial experience, but there's also very specific, particular experiences related to the context of Africa and to the sectors around health. So in this session today, we will have researchers and professional support staff from York, Malawi, Zimbabwe, Tanzania and Uganda, talking about their experiences, the challenges, biases and barriers that they have faced in conducting health research, and ideas and recommendations for institutional change. So we're looking forward to a lively, challenging, critical discussion, and I would encourage everybody to participate by contributing questions and thoughts as we go to the discussion period at the end of the session. Some technical advice. So I guess most people are familiar with the mechanics of Zoom these days. There's a Q&A box where people can type their questions to the panelists during the webinar. We'll have a Q&A session for the last half hour, where you'll be able to raise your hand and present your questions yourselves. If anybody experiences any technical difficulties, we have technical support available. Should you lose a Wi-Fi link, should you need the subtitles, these are also available, and you can turn these on or off. There's a button to use a live transcript at the bottom of your screen. And I'm sure everybody's realized by now the webinar is being recorded. So I just realized I haven't introduced myself as I'm about to introduce the sessions, so apologies for that. So my name is Richard Friend. I really don't have experience in health and African context. My background is in global development, but largely in Southeast Asia. And I'm a senior lecturer in human geography and environment, and one of the research champions focusing on risk evidence and decision making. So I'm really excited to be here. There's a lot to cover. There's a lot for us to learn, and I'm very keen to get things going by introducing our first two speakers. So our first session, and these are very short presentations. We have 10 minutes for each session. Our first session is entitled Celebrating African Public Health Leadership. I'm pleased to introduce Sanjoy Bhattacharya. Professor Sanjoy teaches History of Medicine within the Department of History and co-directs the Center for Global Health Histories, and also serves as a head of the WHO Collaborating Center for Global Health Histories here at the University of York. He's joined by Jokonea Chirenda from University of Zimbabwe. Jokonea is clinical deputy dean in the Faculty of Medicine and Health Sciences at the University of Zimbabwe. He also lectures on communicable diseases and occupational medicine within the Department of Surgical Sciences, and has been deeply involved in national, regional, international, and global health initiatives, both as a participant and an advisor. So we have 10 minutes for both Sanjoy and Jokonea to make their presentations, and I'll give each of you a signal just as we get to 4 minutes, if that's all right. So I'm going to put myself on mute and invite Sanjoy to take over, please. Thanks very much.
Thank you, Richard. Africa is not a country. For me, it is a region with independent states marked by diversity and difference. Marked also, I might add, by the negative impact of years of imperial rule and bad governance, often engineered by Cold War tensions. This is the historian in me coming out. Yet, Africa as a collective of nations has had a proud record of regional collaboration and contribution to success of multiple international and global programs. Here, it is important to remember that health is not just science. And science is not just simply imported into Africa. It is co-produced with African help and participation as I speak, and for years beforehand. Yes, health provision is linked to the application of science, but there are many other things that act as very important determinants too. A, the communication of science and health to communities. B, delivering trustworthy and trusted services. It is in these two contexts where African expertise and government investment has been crucial, consistently crucial. Ever since the successful decolonization of the continent and newly nationalist efforts to create better futures. Jokonea will speak about some of these influences in Zimbabwe after it became independent in 1980. It is very easy for us to look at Zimbabwe, remember the last years of Mugabe's rule, and scoff at what the country has to offer. But such an attitude would be uninformed, possibly racist, and certainly unacceptable. Between 1980 and the mid-1990s, in the mid-1990s, the World Bank came in and destroyed public services to an extent that harmed the Zimbabwean population. Immense structures of education and health were created, that despite years of underinvestment by the Zimbabwean government, continue to play an important role, especially at primary and community healthcare levels today. Their resilience is a testament to the strengths of African expertise and contributions. And I'm so honored to have Jokonia Chirenda, who's one of those Africans who has worked nationally and internationally on TB and AIDS control amongst us, to tell us more about that experience. Sadly, for me as a historian, African expertise has been systematically ignored and willfully forgotten in high-income country government funding and academic structures. Consciously or unconsciously, this is a racist attitude to have. These attitudes need to change for a better global future, one that hopefully also involves the Democratic University of York. Thank you.
Thanks very much, Sanjoy. That's marvelous. And can we pass over to Jokonia now, please?
Thank you, Chair. Can we have the next slide, please? So thank you. So I think I aptly put those three little boys at the corner there because invariably that's the perception that most international funders for health research have when it refers to Africa and particularly Zimbabwe. That there's no leadership, there's no public health leadership at all in most African countries. And therefore cannot provide funding. But I would want to start by giving a brief background of the public health, primary health care system in Zimbabwe. Before independence, there were a lot of inequalities with distinct services for whites and services for blacks, facilities and other things. At independence, I think the first 10 years saw an intentional investments in schools, in new hospitals. The World Bank loan of 1992, mid-90s, ensured that in every district there was a hospital and health facilities. And the idea was to have at least 10-kilometer radius to the nearest health facility for populations in Zimbabwe. And this established not only the infrastructure, but because of the education, a lot of Zimbabweans went to school. For the first time, the medical school at the University of Zimbabwe changed from 80% whites and 20% blacks to more than 90% blacks and 10% white. So we, over a decade plus, the primary healthcare system in Zimbabwe was built. Next slide. So as I was saying, there was a net, because of the investments over the first 10 years plus, before the structural adjustment program of early 90s and mid 90s, Zimbabwe became a net exporter of its health workforce. You go to the Southern African region, even up to today, most health facilities, hospitals, organizations are headed by Zimbabwean health professionals educated in Zimbabwe and working in the region. You go to England at the moment, majority of nurses are Zimbabweans, and I don't want to talk about my colleague who is on the call. So we managed to build a resilient primary healthcare system despite the effects of ESAP and the severe socioeconomic challenges. That has actually failed to disrupt that primary healthcare system, which is still functional at the moment. What we have done in terms of COVID is testimony. We are one of the best countries in terms of COVID response, and it's become a destination of choice for most regional organizations. Some of you may remember when there was trouble in Congo Brazzaville, the Africa Region Office to come to Zimbabwe to stay because of the peace, because of the infrastructure in the country and other things. Next slide. So what sort of lessons have we learned as it relates to the subject of today in terms of health research? There's a severe negative perception about Africa, and Zimbabwe in particular, that there is no infrastructure to successfully support research activities. Most of the international funding partners funders think that no successful research can take place in Zimbabwe. So in terms of success, when you write a grant, I think I've, with Sanjoy, I've attempted 3 or 4 grant writing proposals, which have not been successful. You want to find out why there's no explanation why our proposal has not been successful. So at the end of the day, we don't then get to do priority research for Zimbabwe. You have to go through a partner, another institution, and then you are more like a data collector. You're not particularly doing research that is relevant to the country, and because of that, we tend not to have enough resources to keep on strengthening our systems, and the systems then get strengthened, get hindered. Next slide.
Sorry, Jokane, could we just maybe 1 more minute?
Sure. It could be the last, actually. Okay. Yeah, that should have been the last slide.
Oh, well, perfect timing.
Yes.
Sorry, I didn't mean to interrupt, but I think, I'd like to.
That's your 4 slides.
Yeah, that's marvelous. And I think it really sets us up very nicely for the next round of discussions. And I think as you sort of finish, well, with Sanjoy pointing out the historical dimensions of colonization and the continued history of colonization, I think it segues very neatly into your points about questioning whose values, whose expertise, and whose priorities really come through in setting research agendas. So thanks very much. And please invite the audience to submit any questions in the chat or save them for the final half-hour session of Q&A. Thanks very much, Sanjoy and Jokane. Sorry to rush everybody, but we're going to move into the next session, which is reflections from the tobacco and HIV research experience in Uganda. And for this, we have 2 distinguished speakers, Noreen Umdege from Health Sciences Department at the University of York. Noreen is an associate professor in the Department of Health Sciences, leading and contributing to policy relevant health research aimed at maximizing health benefits within the constraints faced by low and middle income countries. Her current research is mainly focused on tobacco control and covers a number of countries in sub-Saharan Africa, Ghana, South Africa, the Gambia, Uganda, and Zimbabwe, and in South Asia, specifically Bangladesh, India, and Pakistan. And Noreen will be joined by Kellen Nyamarungi from the Makerere University School of Public Health. Kellen is a public health professional with more than 15 years of experience in public health policy implementation. Currently, she is Research Associate at Makerere University School of Public Health, Department of Health Policy, Planning and Management. Kellen has over 8 years of tobacco control experience in research, policy formulation and implementation in Africa, and was co-investigator and country lead for the University of York Makerere University of School of Public Health project Tobacco and HIV. Okay, so Noreen, if I can invite you to speak first, and again, after 4 minutes, I'll give you a signal.
Yeah, that's all right. I intend to take it shorter than that. So thank you so much. And I will be reflecting on our learnings and experience, myself and Kellen, on our project that we collaborated on, which was tobacco and HIV in Uganda. So I think just carrying on from the previous speakers, I think, our reflections, when we started this project was that, as UK institutions and researchers usually come from a position of assumed superiority It could be in terms of expertise on the topic area of research, for example, tobacco control in this case, and also just technical expertise. It could be in study design, questionnaire design, or data analysis, or whatever. We do not seem to take into account that some of the topic and technical expertise that are required by the project could actually be available locally in the country where the project will be conducted. So, and we don't really think about how we could tap into those locally available expertise. And this manifests itself is an equal distribution of roles in our research grants. For example, who is involved in the conceptualization of the research, who is involved in the design or data analysis versus project management or project implementation roles. And that further manifests itself subsequently on the research outputs, who is the first author, who is leading the paper and things like that. So that tends to normally favor UK institutions and UK researchers. And most of the time, we miss opportunities to harness and tap into and also promote the resources that are available, in country. And I think Jokonia, touched on this in terms of, there's an equal distribution of financial resources for research. And that seems to, give UK institutions and researchers advantage over their African counterparts. And sadly enough, I think in some of the research that I've been involved in, people do not seem to regard understanding the context as an important expertise. When it is regarded as important, sometimes the attitude is one that tries to portray that we know enough about the country to be able to run the study independent of the knowledge our partners have on the context, which is, not true at all. I think, it is difficult, to actually think how you can run a study in Uganda, for example, when you are not immersed in the context. So I think, this, manifests itself in very different ways. For example, we tend to impose UK standards in the research methods that we believe are rigorous, for example, and many indigenous research methods that might really be useful in some of the settings that we're working are considered as inferior. This also informs how we evaluate research that is conducted in Africa or is led by African researchers, particularly if it is not in collaboration with researchers in our income countries. This could be when we are evaluating research proposal or research reports. I think something that Jokonia touched on. And in terms of the interventions that we choose to push, in these settings, sometimes you'll be looking at an intervention and wondering who came up with this intervention. It doesn't seem to be grounded within the realities within which people are living within those contexts. So at the end of the day, you find that most of the time we get millions of pounds of grants that lead to nothing because we haven't really tried to work with our partners for us to understand the context. And also, imposing standards around ethics, for example, how we conceptualize what informed consent is and the requirements around that. We seem to forget that the consequences of our research, be they be good or bad, will be felt by the local populations. So rather than us imposing our own definitions of what informed consent means, for example, is it not better for us to work with the local researchers to actually understand what informed consent means in that context within which we are working and work with that? And I think my colleagues will also talk about, the issues around research management. I think there is a lot of lack of trust, unjustified lack of trust in the expertise and our abilities of our partner institutions and collaborators. And we see that every time. I think, I have so many examples of, how this manifests itself, particularly, when you are given, I remember I was working on a paper, where the statistics and statistician was based in Uganda, you know, and after a very, very impressive statistical analysis, you know, when we were reviewing the paper, we got comments like, oh, you have to show this to a statistician. What does that mean when we have a very experienced statistician from Uganda, you know, a very senior and well-known statistician from Uganda who has looked at the statistics part of the paper. So I think we just have to challenge ourselves when we partner at the beginning, when we are partnering with our institutions. I think we just have to be more conscious of, you know, our predispositions for us to be able to build equitable partnerships. Thank you.
Thank you, Noreen. That's marvelous. I mean, really critical points that you raise. Kellen, can I ask you to continue, please?
Thank you, friend. I just want to pick up from where Noreen has ended in terms of trust, and I will present following two lines of thought. One is listening and learning, and the other is building truly equitable partnerships. And I will look at what are the challenges, what can be done, and I will draw examples from our HIV tobacco partnership. Now I'll start with listening and learning, and I'll pick from where Noreen has stopped in terms of trust. Many a times when we are doing these partnerships that we have with high income countries in Africa, we realize that there is an assumption that they understand and have knowledge on the context, especially in Africa. So they come with terms or dictate terms in terms of what research agenda should be, you know, undertaken, the topics, the methods and everything, including things like what Noreen has mentioned, consent and so on. And also they look at the African continent as having poor management of ethics. And of course, the other key thing we need to look at or understand when we talk about listening and learning is to look at the differing expectations. So in listening and learning, as we build these truly equitable partnerships, we need to understand that dictating terms will never work. These partnerships go on, but later on you realize that, like Noreen has said, you wonder where this study was conceptualized from and what is the use. So what can be done? Take time to immerse yourself in the context. I think that is very important. Listen and learn from the in-country partners or teams or colleagues, and take up secondments in your partnership institutions, like building the teams, understanding the expertise, their knowledge, without prejudice to say, okay, maybe this one cannot because of the title or because of the expertise. Now, how did we do it with HIV and tobacco? One of the things we did very well was to understand the research agenda setting. We walked through, we had enough time to walk through the requirements. You know, we dialogued about the requirements of the grant. We dialogued about the study we want to do. We talked about cultures because we had both quant and qualitative, and we're dealing with a vulnerable population, that's HIV, people living with HIV. So we took enough time to understand, you know, the context, and we also distributed leadership roles very well based on comparative advantage, but also most importantly, expertise. So that helped us a lot to distribute our leadership roles, and also to be able to allocate, you know, our resources very well. We discussed through who will do what, who will lead on what, including the leadership on papers, you know, who is the main author, who is the lead author. And that helped us a lot to come out with 3 papers, and each paper had leadership. Leadership was well distributed, UK and in Uganda. The second point I want to raise on learning and listening is lack of respect to political and cultural context. We've seen that a lot, and Noreen has hinted on it, imposing standards, imposing agendas, and so on. And this, of course, we need to understand the needs of individuals, institutions, and their expectations, but most importantly, to align institutional goals, individual goals, and then the funding agency goals, but also the country research agendas. What are the goals of the country research agendas? I think that is very, very important. And how did we handle this in the HIV and tobacco study? We were able to interrogate. I remember one time we were discussing the clinics and how we, sample the clinics and what is the political divide in Uganda, and that helped us to come up with a good number of clinics across the country. The last point I want to discuss is under building truly equitable partnerships. And the challenge we have seen majorly is power imbalance. And my colleagues have been talking about this. We have an equal distribution of tasks and facilitation. We have skewed leadership, usually to the high income countries. And the Africa takes on the mediocre roles, and yet the weight of the study is actually down in Africa. And then the other one is, of course, the limited resources and mode of funding. Sometimes those also skew, or bring about power imbalances because the donor is asking this and that and that, and therefore researchers are torn between balancing, power and roles as well as facilitation. What can be done? Look at comparative advantages and expertise of both the individuals and institutions. I think that's very important. You find a university like Makerere, it's 100 years. So its policies, its programs, it's handled, it's huge grants, and researches. It's a global university, to be honest. But when you get some partners saying, no, we can't use your policies, we can't work through these, you have to draw a new policy, we have to understand your data management, structures and everything and policies, and that takes a lot of time, but also undermines, leadership at that level. The other thing we need to do is to have open and honest dialogue and to structure the leadership in terms of expertise and comparative advantage. How did we do this with the HIV tobacco? We were able to have a good open dialogue sessions all through from conceptualization to the end. So open dialogue was one of the key attributes that we had. Budget allocations were well done. We discussed the budget in and out, and colleagues in New York actually were not paid. Most of them, Noreen wasn't paid. But we said, okay, what does it require us to be able to collect quality data and be able to accomplish this partnership? And that helped us to also think through the budget and be able to allocate. There was transparency throughout the whole process. And we had a good idea of what everyone, the role, analysis and allocation of what each one was supposed to do, and where we had shortcomings were able to come in from either side, either York or Uganda, to be able to cover up. And that helps us to complete within time and within the minimal resources that we had. Finally, what were the challenges that we faced? Of course, everything that glitters is not gold. So we're able to, we had one huge challenge, which was bureaucracies, especially in our ethics. In Africa, we have two ethical clearances. One is the technical, the IRBs, that is faster and okay, but we always have the political clearance usually, and that takes some time because they have to be clear what you're doing and if you're not affecting the political sovereignty of a country. Thank you very much.
Thanks very much, Kellen and Noreen. I think that's, again, really important, powerful insights from the position of assumed superiority to the sort of practicalities of how roles and responsibilities and knowledge and power play out in implementation of projects. I have a few questions, but I'm going to have to save those for a bit later. I'm sorry. We're going to move on now to the next topic, which is mental health research experience in southern Malawi. And we're going to invite our colleague Jerome Wright, who's from the Health Sciences Department at York, Jerome is an associate professor in mental health in the Department of Health Sciences. And as a member of the Mental Health and Addiction Research Group, Jerome's research focuses upon people's meanings and experiences of psychological distress, with a particular interest in cultural expression and help seeking. He has led a number of research and community health development projects in Malawi and continues to collaborate with a number of international NGOs on HIV, AIDS, and mental health initiatives in Africa. So over to you, please, Jerome. And again, you've got 10 minutes, but perhaps a little bit less if you don't mind.
I'll do my best. Thank you very much. Thank you, Richard, and thank you, everybody. I'm going to share some slides really so that I can show some photos so you don't have to keep looking at me. And as I do that, I'll try to do that. Here we go. As I do that, I want to thank you for inviting me to speak on this. And I suppose I'm going to move from the fascinating insights that we've heard so far nationally and sort of globally to really focus in on a very individual local experience. And I'm going to talk a bit about that. But as I begin, I want to just say that although I'm going to present some experiences and ideas, I want to acknowledge all the skills and expertise of the huge number of health workers that I work with in Malawi, and particularly also to two colleagues. One is my colleague Limbika Malawichi from the University of Malawi, Chancellor College in Zomba, and also my colleague here in York, Janaka J. Wakarama, who I've worked with, have really helped and supported some of this work. But as I say, what I want to do is to share an experience. So I'd like you to try and picture a scene in a small room in a hospital in southern Malawi, where it's the end of the dry season, which helps with travel and accessing kind of remote areas, but is kind of paid for with a quite sweltering heat. And a group of a dozen people are attending a week-long series of workshops where they're designing a curriculum to train village health workers to assess and care for people with what psychiatric classifications sort of describe as common mental disorders or severe and enduring mental illness. These are the sort of problems that village health workers were encountering in their practice. So we assembled is a group that consists of the one psychiatrist in the country, some clinical officers, nurses, doctors from the nearby College of Medicine, representatives from the MHACAS, the Mental Health Users and Carers Association of Malawi, and also some of the village health workers, the group of staff that were to be in receipt of the training. Now, at one point in the workshops, one mental health professional, an academic from the UK, offers an observation that he'd noticed in kind of everyday discussion in the community in Malawi, a miambo, or a kind of a local custom for people not to ridicule or to denigrate a person with disability. And it's kind of often expressed like in a traditional proverb, so it's well known. And that perhaps this might be a useful way that health workers can convey the anti-stigma message around mental health, mental illness, etc. This proposal was met with an initial silence. It was really clear everybody in the room recognized and were familiar with the miambo. And then the mental health professional colleagues in the group began to respond gently but assertively that using such a message wasn't suited to an evidenced biomedical position or to the modern approach to mental health care that they were trying to convey. And that association with traditional ways of thinking would reflect negatively on the village health workers and on the message. So now it won't surprise you when I say that, of course, I was the mental health professional, the academic in the room, but together with those Malawian colleagues over the next 4 years, we worked very closely to develop the curriculum, to deliver the training, to undertake the structured evaluation. So we showed how you can train more than 700 workers across the whole district. They could then provide a first response mental health service attached to primary care. and working with people with all severities of distress and crisis. And also working with communities to raise awareness of distress and challenging stigma towards mental illness. Now, as many of you, I'm sure, will know, such a program and evaluation ticks many of the boxes prized by the global movement for mental health, the global mental health movement, where this and other task-shifting projects respond to the call to scale up services or to meet the mental health treatment gap, the gap that's said to exist between the adequate provision of services and the number of people who are deemed requiring that support. But this exchange that had occurred still troubled me, like what was happening in that room? Because as a white European and outsider, there was absolutely no likelihood whatsoever that I'd come up with anything novel or new to Malawians' understanding of their own cultural mores or place of such thinking. So what was behind this reluctance to include traditional thinking? It was curious because everybody in the room had like a really genuine and heartfelt commitment to assist people in distress. And as the project progressed over the next few years, we deepened then our understanding of the interventions that the health workers were actually using. And when we looked at these interventions, what became more and more apparent was the noticeable differences from the training to the implementation of the interventions, from the curriculum as originally designed to the delivery. The three common interventions: practical support, counselling, and support group. Practical support, far from it being simply transferring resources from A to B, it was mobilized through the existing traditional and sort of community structures, and exerted all of this under the traditional meanders of reciprocity and social insurance. So it was an enactment of collective support in the village. Counselling too differed from counselling that was taught. It was adapted to the context, so that the people in distress were reacquainted, reconnected with their place as an individual in the collective cultural setting, more directive, but achieving that aim. And in similar way, the support groups operated, but they had a really tight facilitation, almost a scrupulous respect for hierarchies of participants, like age, gender, place in the community. All of this reinforced their individual value and their personhood. Now, all of these interventions can be seen to have been adapted to the cultural setting, to the social mores. And in that respect, Ubuntu, the Malawian version in the sense of Ubuntu, of personhood, this rich traditional philosophy that informed everyday practice, was being enacted, was being proposed through these interventions. This wasn't what was taught, but this is what was being enacted. Now, anyone who's familiar with kind of sociocultural approach to psychology will know this kind of thing. This means that cultural meanings and practices, they aren't phenomena that culture doesn't happen to us from outside and to which we kind of relate. They represent the aspects of our internal world. They inform the way we think, the lens through which we understand and experience life. So it makes it really problematic to assert a particular way of understanding and responding to something as nuanced and constructed, like socially constructed, as distress. And because mental health and well-being is so impacted by the social and cultural world, aligning the understandings and treatment perspectives with that cultural setting is critical. And that's what the village health workers were doing. So what happens when globally dominant assumptions impact locally, where there may be assumptions of gaps in terms of treatment, in terms of where there's rich seams of sort of traditional philosophy and thought, that might be even be said to be silenced, to be ignored and perhaps silenced. So it has been deemed an epistemic injustice, and as a contemporary form of colonialism, enforcing a particular value or a particular worldview. In this case, you could argue the dominance of a biomedical explanation and treatment. So what of the village health workers' adaptations to this situation, and why did they adapt in this way? What was going on, and why wasn't that overt in the training? Well, this has been described by China Mills as like an invisibility, where workers that are charged with delivering a biomedical intervention actually adapt them, and that's a familiar response to those exposed to like a colonial endeavor. So it's almost under the gaze or the guise of a colonial power. So what of my experience of the workshop? Why was that suggestion rejected? Well, to progress the resemblance with colonialism and colonial powers, there's been a long established use of local interpreters to impress a modernizing mission, those who will accept and relay those understandings. In this case, it's propelled by globalization or a psychotrizing like agenda. But this isn't to, like, I don't mean this to censor the interpreters. They were adapting to the context in which they found themselves. They were managing different types of knowledge of globalization and of power dynamics. And as I said, everybody in the room was well-meaning with positive intentions to serve how best they can the vulnerable, distressed people. But what was important here was the lack of acknowledgement of these dynamics, I think, the lack of room for open discussion and debate over the benefits and the limitations of both traditional understandings and biomedical solutions. So the failure at that point was mine.
Would you mind if we can wrap up? Sorry.
But it's a failure that continually fostered by universalistic sort of global mental health assumptions. So to draw conclusions, there are always tensions, you know, whether it's a critique of medicalization or a romanticism of the traditional. But when we try to move forward positively with research partners, we need to approach this with humanity and humility so that all mental health care initiatives are co-created with the respect, I think, for the community's historical as well as contemporary context. And so that collaborative partnerships are respectful along lines of social justice and cognitive justice. Thank you.
Thanks very much, Jerome. Yes, and I think you hit on some really important points for us to discuss in terms of the sort of the practicalities of challenging these epistemic injustices in the way that we approach and receive funding and the way we design and implement research projects. So thanks very much. We're going to move into our next session, which focuses on research administration, contracting, and financial autonomy. So a good follow-up to some of our earlier discussions. And we're welcoming Edward Kataika from EXA HC. Edward is Director of Program at the East Central and South Africa Health Community, a health systems development expert with 20 years of experience in health management, planning, and economics. Edward oversees the ever-growing portfolio of programmatic and project activities at EXA HC and is the Chief Advisor to the Director General. And we're also welcoming Alexandra Rollinger from Health Economics at University of York. And Alexandra is Project Manager for the Center for Health Economics Global Health Team. She's responsible for supporting and managing a number of multi-partner projects led by Center for Health Economics, focusing on developing and applying health economic evaluation and impact analysis methods to healthcare challenges facing decision makers in low and middle income countries. This includes CHE's flagship global health research program, Tanzania and Uganda, Health for All in Malawi, Uganda, and East Central and Southern Africa, and the NIHR Global Health and Econometrics and Economics Group in Brazil, Indonesia, and South Africa. So thanks very much. Again, we have about 5 minutes each. I'll give you a little a sign. We're getting close to that time. Edward, please, over to you. Thank you.
Yeah, thank you very much, Chair, for that introduction. Let me add that EXA Health Community is an intergovernmental organization that promotes cooperation in health among its member states. It currently has 9 member countries drawn from the Eastern and Southern Africa. We collaborate with the University of York Center for Health Economics in facilitating research to policy initiatives at the regional level. We are a member of the Tanzania or Health for All research program, which is led by the University of York Center for Health Economics, whose primary aim is to improve resource allocation capability for healthcare decision-making in the EXA region. Other collaborators in the research program include UK universities, but also universities and the ministries of health in Malawi and Uganda. So Tanzania is currently our main research program in the collaborative, but we collaborate with the University of York and other UK institutions in other related health programs. So my reflections on research administration, contracting, and financial autonomy are based on the organization's experience in collaborating with UK universities in these research programs over the last couple of years. Let me start on a positive note by mentioning that we find the collaboration with UK universities beneficial, as this avails us the opportunity as an African institution to access financial resources which would otherwise not be easily accessible outside the research collaborative. So the collaboration avails the experts from our member countries an opportunity to interact and exchange knowledge and skills with their UK counterparts. I find this to be a good model for research to policy capability building. Now, one challenge that we experience in as far as administration and contracting is concerned is to do with the due diligence, which we as an African institution is subjected to before receiving research funding. There's a lot of information that is demanded by the lead UK institution as part of the contracting process. This ranges from financial management issues. We get questions like, if the organization has a bank account, how expenditures are accounted for and reported, the frequency of audits, and such other questions. We are also asked about organization policies relating to corruption, fraud, or if staff have insurance cover, professional indemnity, sometimes even going as far as asking us to describe the economic and political situation of the country where we are based. Now, it's well understood that due diligence is a standard procedure which forms part of the grants management process. And it's not only UK research institutions that subject us to due diligence. Virtually all funders do this. It's also understood that this is done with good intentions. That is to understand the nature of the risks involved in funding other institutions and possibly put in place some risk mitigating measures. I, however, believe that the demands for information and the frequency at which the information is required tends to be rather excessive. For instance, in a situation where EXA has an ongoing collaborative arrangement with the University of York and other UK-based universities, it may not be necessary to conduct due diligence every time the collaborative prepares and submits a funding application. It would be less burdensome if due diligence is conducted once, probably at the beginning when you are starting the partnership, and such information is used in the subsequent funding applications or contractual processes, because usually much of that information remains the same. If we are being asked about financial management systems or the policies that the organization has, these usually don't change like every year. The information remains pretty much the same. So it's something that can be used over and over again. We don't have to be asked to submit this information every time there's a requirement to submit a funding application. One can imagine that an organization like EXA, which has several partners, and each of them conducts due diligence, some for every single funding opportunity that we are pursuing. Quite a lot of times, quite a lot of time is spent on such paperwork, and the staff involved in this sometimes wonder if this is really necessary and if it's the best use of their time. So one observes waning enthusiasm on the part of the staff working on this, as you ask them to fill in yet another form to fulfill requirements for a particular funding application. So this fatigue associated with compiling information and filling in lengthy due diligence forms, which comes as part of research funds mobilization, ought to be addressed somehow. That's my view. Lead institutions should consider exploring ways of streamlining contractual processes, particularly the information demands that form part of due diligence for African institutions. So this is my reflection now, and I thank you, Chair, for the attention. My colleague Alex is going to reflect more on this. Thank you.
Thanks very much, Edward. Yes, good points. So maybe we can pick up in the Q&A session. Alex, please, could you take over?
Brilliant. Thanks very much, Richard and Edward. Yes, my reflections are based on kind of personal experiences during the health research programme Tanzania and Uganda, which has already been mentioned. I personally have learned a huge amount from African colleagues throughout the life course of that programme. However, I wouldn't like to claim that I or we as a team get things right every time, nor that we don't have a lot of learning still to do. The suggestions that I'm going to put forward, however, represent a critical assessment of our actions here in York based upon these experiences and presenting some ideas of how we can continue to improve in the future. So as Edward's already said, administration of global health research projects is an equally important aspect of building equitable partnerships between the UK and African research communities. Be this through the drawing up of work contracts and data sharing or intellectual property agreements, or through the administration and distribution of budgets and other resources. But the neo-colonial attitudes which have been described by earlier speakers today also unfortunately exist in this sphere of research too. And I do believe that it's our responsibility to identify and tackle these with the same determination as those in the academic arena. So there are two examples that I wanted to highlight specifically, and which Noreen and Edward and Kellen and everyone has already kind of touched upon. The first of which is contracting. So in the UK research sector, major research funders such as UK Research and Innovation, known as UKRI, and the National Institute for Health Research, or the NIHR, have very strict requirements for research contracts. So a single leading research organisation is identified as the contracting lead, which is responsible for all of the contracting between project partners and the distribution of funds to these partners. These contracting leads end up being more often than not UK universities, and Jock and I has already mentioned this, and it's a topic that could have its own event to discuss in full. But the situation kind of results in an implicit expectation that project contracts should follow a UK approach, with a UK-centric attitude towards matters such as institutional insurance cover, Edward's already mentioned. So as a frequent contracting lead, we here in York, as well as other universities, end up passing these expectations on to our research partners. And this creates a problem when partners operate processes that do not fully match that UK approach, or who have requirements that are not as big as a concern for UK institutions. And this issue can lead to delays in these partners receiving their funding and stripping them of their financial autonomy over their duly awarded research resources. And we therefore inadvertently end up penalising partners for simply not being set up in the same way as a UK university, or forcing them into unfair compromises in order to kind of make them fit. So in other words, sign up to the contract agreement or you don't receive your funding. The second point I was going to raise was a matter of due diligence, but I think Edward's already covered that really well, and I don't think there's much more that I could really add to that. But again, speaking from the UK perspective, I think due diligence too is kind of framed in this UK model. It's defining what is safe research according to a UK standard. Noreen mentioned this as well. As such, I don't think that it always adequately reflects the huge number of diverse contexts in which research partners operate. And conversely, partners outside of the UK often face the greatest administrative burden with due diligence. Again, Edward's mentioned this. So UK university partners are often spared by the very nature of belonging to the same consortia as York, so being part of, for example, the Universities UK Concordant to Research, support research integrity. So this mistrust of African and other foreign partners undermines efforts to build equitable partnerships, as well as stretches these partners' administrative teams beyond capacity if you're having to juggle multiple due diligence requests. So there have been international initiatives designed to overcome this issue. For example, the Good Financial Grant Practice Standard, or the GFGP, which was designed by the African Academy of Sciences some years ago. However, this hasn't really been fully adopted yet by all UK funders and universities. Here in York, the research integrity team is continuing to explore and champion solutions to this issue at an institutional level. And we've used the GFGP for a couple of years now. Due diligence remains, however, a major barrier to our work with African colleagues, as Edward has mentioned. And without a more sustainable solution, York and other UK universities will risk earning a reputation as an administratively burdensome and a non-trusting partner, and we could risk losing out on valuable collaboration opportunities as a result. Before I finish, I just want to provide a couple of suggested solutions that we here in York may want to consider to make meaningful changes to address these issues. Firstly, alongside supporting greater shared learning and interaction between York researchers and partners in Africa, I'd like to see the university commit towards supporting professional support staff to speak, meet, and spend time with their counterparts at African universities to gain a better insight into partners' contexts. From my own experience, it's only been through meeting with project management colleagues in Malawi and Uganda that I've made progress towards addressing my own ignorances on these matters and gaining a better appreciation of why UK approaches to project management are not always doable or appropriate in different environments. It seems that this approach would be particularly impactful when applied to due diligence. Having a frank and open conversation between UK and African partners about the potential risks to the project and mitigation processes already in place at all institutions would help York and all partners to gain a greater understanding and appreciation of each other's contexts. And I'm aware that this idea is currently being explored by the research integrity team here, and I welcome their commitment to addressing this challenge. And lastly, as a second point, York, as a recipient of resources from the Global Challenges Research Fund, or the GCRF, which is the UK government's £1.4 billion research initiative, which was launched back in 2016. I think that we could do a lot more to lobby major funders to revise their contracting statements to better reflect the diversity of research funding recipients and or can protect contracting leads so that they have the flexibility to produce contracts that are better attuned to the needs of project partners. So I'm going to stop there. Thank you very much for listening. Apologies for the alarm that went off halfway through that. Happy to take any questions, but for now, I'll pass back to you, Chair.
Thanks very much, Edward and Alex. I think it's really important that we focus on the practicalities of managing grants and research partnerships. In some ways, I'm a little bit, I think there's a lot to learn from the practice of development intervention, but I can't help but think this discussion about due diligence and risk assessment, perhaps our African friends should conduct a due diligence and risk assessment of UK funders. I think that would reveal some really staggering insights. But I don't want to abuse my position as chair too much. And I'd like to move on to invite Pauline Esser to provide a sort of final commentary on what we've heard and what we've discussed. Pauline is the Director of Research and Insight at Education Sub-Saharan Africa, where she focuses on improving access to and the quality of tertiary education in Sub-Saharan Africa. She and the team bring together a network of African students, institutions, funders, and policymakers, and provides them with the data and evidence they need for effective decision-making. Prior to joining ESSA, Pauline worked at the UK's National Institute for Health Research as a senior manager for global health. And she also spent 9 years at the University of Cambridge, where she was instrumental in establishing and managing the flagship Cambridge Africa program. So we're delighted to have Pauline to provide this commentary. Over to you, please. Thank you.
Thank you very much. And yeah, it's a pleasure to be here. Thanks for the invitation. I've listened with much interest what's been discussed so far by my fellow panelists, and it's great to see what's happening at York. Obviously, there have been positives, but also areas that we need to look into more deeply. And I think even opening up this debate is a great way of showing that those of you at York are willing to listen and learn and do better. Not that you're not already doing a great job. I'm coming from this, because of time, I won't go through everything that has been said already, but I come from this. The positives I see in terms of building these equitable partnerships and collaborations is that it has to be win-win for both sides. The focus should be on equitable partnerships that lead to mutually beneficial results at the end of the day. And collaboration, North-South, South-South, really does bring something different to what we do as our everyday business in universities. So definitely that leading to innovation by bringing together different ideas from North and South, but of course needing the local understanding of what's happening on the ground, what has been tried before, what worked well, what didn't, why didn't it work, before we bring in the new ideas coming in. And for sure, as my colleague said earlier, you cannot just pilot something from the UK and go and expect it to work within Africa. There's so many examples of projects that have been brought down as a top-down initiative and they just don't work. So definitely that local context is important. And those who are living and working in these African institutions honestly know best what is needed on the ground and should be in the lead for addressing these issues. But by all means, collaboration is a powerful thing. As I said, that co-creation, knowledge exchange, co-development of solutions, bringing in different ideas from elsewhere, packaging it with the local context in mind, can bring about innovation, the curiosity of young researchers can be fulfilled, and it can actually lead to tangible, sustainable change, capacity building, strengthening on both sides. I've been in this business long enough to see UK researchers benefit so much from these partnerships in terms of getting more grants because they understand the problem better and can work with African partners to address those problems, publishing at a faster rate than they would, sitting in the UK trying to address global challenges. And obviously you cannot leave out a whole continent from global research, especially when a lot of the challenges that academics are interested in understanding, we've got many of them in Africa, not by design, but they're just there. And so it's a richer environment for understanding these global challenges. So partnerships that are set up in the right way can really help to address those. So those are some of the positives that I see in that respect. I mean, I've seen so many medical students from the UK go out to Africa and they learn things that they would never ever see in reality unless through textbooks. And they experience health research for how it really should be. And they come back with a vision for why they want to be doing this work and why they want to help advance people and bring about socioeconomic development. But I guess there's always that negative bit. Sanjoy talked about the historical context, and I think it's important to bear that in mind because there are racial, whether intentional or not, these run through partnerships often, and they can lead to short-term partnerships rather than sustainable long-term ones. I've seen partnerships that have run for 10 years or more because they were built on a strong foundation. As Helen gave examples of in their partnership, if you do it right, it can really last a long way. And so what I see, for me, it's about the power of why. Why are you getting involved in these partnerships? What do you expect to gain out of it? And answering that question honestly and understanding, is it about self-interest or is it about mutual benefit? Is it this top-down thing about white man savior attitude? Because in fact, many Africans are fed up with that attitude. And honestly, they have other options. They could go elsewhere for partnerships. But it's in the UK's interest to engage. Soft power can be a good thing, but we don't also need people creating dependencies. It's almost as if we get involved in the research, but then we never really get to the solution, because if there's a solution in place, then the Africans are free to go and they don't then need to depend on UK partnerships. And I don't think that's the right way. And thankfully, there are only a few who are doing research in that way, but it can be really toxic and it's not fair. We talk about fairness, transparency and all that. And often it is very difficult being an African in a partnership because there's so much exploitation that goes on in some contexts, not everywhere, I'm generalizing, but we do see it and we feel it. And it's difficult being a partner when you are experiencing those kinds of negative attention. It affects how you work. And so for me, that big why, is it just about research income generation because you may be able to get more funding if you are focusing on Africa? Those ones can end up overnight being destroyed. We've seen what happened with the ODA funding. Overnight, the tap was turned off or closed to some extent. And so if your partnerships are based on only what you can get from GCRF or NIHR funding or whatever, then that is not really a strong basis to be engaging in this partnership. And in terms of what else we can do to bring about that more of that equity and diversity and inclusion. I mean, you're doing the research, but also many of you are lecturers or teaching. How are you incorporating those partnerships of what you know about the African health research into your curriculum design in terms of your teaching? Do you have African books in your reading lists for your students? Do you have case studies of African research and health contributions in what you are teaching your students? I mean, there's so many examples of great African contribution to health research. I mean, I've got colleagues from Makerere who are on the panel today. Nelson Sowan Campbell from Makerere University was a big contributor to health HIV research in the 80s when it was called Slim's disease. Are they appearing in any of your teaching and learning? Dixon Chibanda from Zimbabwe, innovative, bringing in the friendship bench that is being used in terms of mental health, addressing mental health. I've seen so many examples of this bench being used outside of Africa, but there's hardly ever any reference to the source who came up with this idea. So it's about giving credit to our African colleagues for what they bring to partnerships, what they bring to innovation in the health space, and not silencing their contributions and hoping they'll just go away. In terms of research, management and administration, absolutely, the GFGP, the Good Financial Grants Practice, is meant to bring equity in terms of these due diligence and reporting. And I was part of the team that was helping to set this up through the African Academy of Sciences. And as rightly said by Alex, it's been adopted by some, but not others. And it is because it's now challenging everyone to look at what's working well or not within their own institutions. And I think part of it, unfortunately, is also because it's come out of the African Academy of Sciences. I can assure you if this was coming out of the UK Academy of Sciences or its equivalent, this would be taken differently. So we do need to question how and why we are involved in these partnerships, whether there's due respect being given to colleagues, whether we are learning and giving credit where it's due, and not always expecting to take, but that we give back as well. I'll stop at that point. Thank you very much.
Pauline, thanks very much. I mean, I think these are, you set up the discussion very neatly on some very key areas that I think does require some hard critical reflection for us in York. We have about 15 minutes for questions. I can see one question in the chat. Is Laura still here? Perhaps Laura could if you could raise your hand, you could actually ask the question yourself rather than have me read it out. Hi, Laura. Would you like to go ahead, please?
Hi there. Can you hear me okay?
Yeah, loud.
Hi there. Yeah, I was just reflecting on some of the challenges around, working effectively and equitably with global health partners. And a lot of that appears to be related to, at least part of it, the high upfront costs that are largely borne by low and middle income partners in this. And I just wondered whether or not, because of that, it just requires a totally new approach to funding research in this area, or whether or not there are modifications that we can make to what the system that we have at the moment, where there are these high upfront research costs, and work with that, or whether or not it's a clean slate, and thinking about how we can manage this most effectively. It just appears to be a cost that at the moment seems insurmountable to many partnerships, and I just wondered if it's kind of worth reflecting on if it's something new or modify the existing. And that's aimed at anyone that's kind of spoken at this panel today. No one specific.
Thanks very much, Laura. Great question. I wonder if anyone would like to begin to answer that. We could invite a few of our colleagues to do so. Any volunteers?
I can start on that, having had the opportunity to work within government ODA funding space. So part of my role at the NIHR was to again look at how we can change the way funding is allocated. As was mentioned by Alex and others, all of it seems to be being channeled through UK leads. And it was time to actually look at things differently and say, we have trust, there's expertise in low and middle income countries to lead on some of these projects and to be involved in leading their design. And so during my time at NIHR, that was the first time we actually had calls put out where African or non-African could lead or co-lead on some of them. And so one of those was the Global Health Centers call that came out in 2018. And for me, that was, it's a pilot, it's something they're looking at to see if it will work or not. But I think being able to understand what the local funding needs are, what they're being requested for, but also finding ways to get some buy-in. We need to think about a way of sustaining this model. It shouldn't always be just UK funding going out. How can we bring in co-funding of some of these projects to also get buy-in, get ownership, which is why the Newton Fund approach was a nice one in which countries actually contribute funding, and then it's seen as more equitable and you've got more rights. For some reason, that hasn't really caught on. So, but I think it's useful or important if the researchers, the academics in the UK can also put their voices to some of these things to push for this kind of change, because a lot of the blame is coming your way. Whereas, as Alex rightly said, it's the design of the funding coming through from different funders that is also putting that burden in there. So I think more of a discussion about co-funding. So it's not always top down, and that some of these requests for due diligence procedures and whatever, we can put a stop on that volume of demand if someone else is putting their money in. So I'm talking about African governments and other sources of funding from Africa as well to make it more equitable.
Yes, Pauline, thanks. I think, you're right. There's lots of different models of funding that we could be exploring and that have been applied in different sectors and different contexts. And we do have agreements on aid effectiveness and donor harmonization and other principles that could perhaps be drawn on and adapted. Sorry, Sanjoy, were you... would anyone else like to speak to Laura's question? Noreen?
Yeah, I think just adding to Pauline, what Pauline said, I think unfortunately, most of the time, these opportunity costs, these upfront opportunity costs don't seem to be seen by anyone. So they are not really, I know funders have tried to address this. For example, for some of the calls, like Pauline was saying, for NIHR calls like the Right call, if you are chosen to go to the second stage, you are given a £10,000 grant to be able to, to use to refine your proposal and things like that, which could really, really be useful for people in, for institutions and researchers in low and middle income countries. However, it only comes at the second stage, rather than actually thinking what we can do from the beginning just to cushion those opportunity costs, to allow, the release of our African colleagues to be able to, congregate and write these grants. So perhaps it might be that there might be some thinking that needs to be done around, our funding schemes and how we, distribute the funds between, along the continuum of actually writing the grant to actually, getting it. Thank you.
Yes, thanks very much. Yeah, I think that's absolutely right. And I think, another point that we have to sort of reflect on is to think more critically about where this funding is coming from. And I think many of us had our reservations about GCRF funding and what its real ambitions were and what its function was in filling a gap in other forms of research funding in the UK. And perhaps we need to be more savvy and more aware as we engage in some funding streams, or not, choose not to in others. Are there any other questions coming up? Oh, Kellen, sorry, do you have your, please?
Yes, I just wanted to add into the question and what my colleagues were mentioning in terms of allocation and the opportunity cost, especially the upfront costs. That over time hasn't been like financed or provided with a budget, and it's kind of like an important stage in agenda setting, but also in writing out the grant. And when you look at low middle income countries and their institutions, it is also not a budget that is available. So individuals have to like foot probably those costs, individual researchers, or if they have funding elsewhere, then they have to, pool resources to be able to support them to participate in this stage, early stage, and yet it's an important stage. So I would recommend that as we continue this discussion, certainly it's a huge discussion and it needs to start somewhere. And I don't think it will be addressed immediately, but it's a conversation that we can push and try to, bring the two partners, like Pauline said, it's a win-win on board. And I like the suggestion of co-financing. I think that is a discussion that must, get onto the table. Why sometimes we find that we have that unequitable partnerships is because the funding is coming from one side. The funding is controlled from one side. But if we can co-finance, then it's very likely that the partnership will be healthy or more healthier for that matter. So it's a conversation that we should bring on the African continent, but also on the other continents. I know that GCRF had started that conversation. I participated in 2 of their meetings, I think one in Dar es Salaam and one in Malaysia, to look at how we can, increase or build truly equitable partnerships in research between high and middle income countries. So I think the co-financing is important for us to look at the continent, African continent, contribute to research meaningfully. Thank you, Chair.
Thanks, Kellen. And I remember you mentioned something in your presentation about, being very clear about where the benefits go, to whom the benefits accrue in these research projects. I think that's also a really important point. And sorry, I see, Edward, you've got your hand up as well.
Yes, I think a very quick one, maybe just to add to what Kellen has just said about co-financing. I believe that this is a conversation that we indeed need to have, particularly with the African governments. And when she mentions this, I remember, I think it should be in the health sector, where the ministers, African ministers of health, actually made a commitment to allocate at least 2% of their budgets to research. And I think this was coming out of the same concerns that research seems to be, funding for research seems to be coming from the West mostly. And usually, well, it is felt that the agenda, the research agenda, is driven by those who are funding. Naturally, the African governments don't have much say. And they were saying, we also need to be co-financing this. But what has happened practically I think it's over 10 years since that commitment was made, but you see that most countries still fund very little, less than the 2% that they committed to doing. So I believe that this is the conversation that we need to bring to the African governments, that they contribute something to research. Maybe this could help address some of these issues we are discussing here. Thank you.
Thanks very much, Edward. Yes, thank you. Yes, an important conversation around funding and where it comes from and who controls it, certainly. I see there is another question in the chat. Laura, this is from Paul via you. Do you want to read it out?
I'm not sure if Paul's able to speak himself on this. I don't know if you're there, Paul.
Hi, Laura, and hi, Richard. Sorry, some real problems connecting for this. Just to say it's been fascinating webinars, really insightful to hear all of the talk. So just a question which maybe a number of us confronted with currently who wish to work in partnerships with colleagues across the world, and it's how to do that best and well currently, given present concerns with global warming and the harm caused by air travel. I guess for most of the past 2 years, we've all had to work remote using Zoom and the like. I think something's been lost from that, and I just wonder. Just a bit of an open question. How can we, feels like face-to-face meetings and engagement, working together, people coming to York researchers going to spend time with colleagues in Africa is important, but how can that be done, which is also environmentally friendly as well?
Right, thanks very much, Paul. I think that's a very crucial question as well. I'm not sure if anybody would like to volunteer to respond to that. Yes, Pauline, thank you.
Sorry, my mute button. Just to say, it's definitely the pandemic and not being able to travel for a while has, again, leveled the playing field in some respect in terms of travel, especially for African researchers, where there was no longer the need to go and queue for visas and explain why, as a professor, you need to be given a visa to come to a conference in the UK, and also the cost of travel, which is also highly burdensome. That was in a way erased. But I definitely think you can only take Zoom to a certain extent. Face-to-face is important. And I'm talking about travel in both directions. So Africans coming to the UK to internationalize their research, to see how things are done here, what's worked well. When I was in Cambridge, people were coming to see how an 800-year-old university has got where it is, the mistakes they've made along the way, what they've learned. It can help leapfrog what we're trying to do in Africa. But what was really important was getting the UK researchers out to Africa to actually meet people, see what happens on the ground, what the challenges are, but also to get them to understand how we can work together to address those challenges. That was an eye-opener for a lot of people who, for one reason or another, are stuck here and have been taught certain things right from school age. They've been grown up thinking a certain way about Africa. And so going out there, meeting the people, understanding the local context, they come back buzzing with ideas for what else they could do in collaboration, come up with a different perspective. I used to call them the converts. They would start preaching about Africa for me and getting people to go out there. And I think that bit is missing at the moment when we're not able to travel, really understanding that local context. But I think in respect to the green side of it, yes, we want to watch our carbon footprint. So I would suggest that when we do go out, either way, we do as much as we can, provide lectures, courses, training workshops, do as much as you can within one trip rather than having several trips. But definitely let's not lose that face-to-face. It's important. It brings a different dimension to the partnership. Thanks.
Yes, thanks, Pauline. I think you're absolutely right. It's important to make good use of funds and travel time available. You remind me of when working in Laos, when international so-called experts arrived in the country, they would spend the first few weeks or couple of months traveling and living in the villages before they were allowed to start working. And I think, it's a good model in many ways. Do we have any more? We're pretty much on time now, so I wonder if any of the panelists would like to offer any final reflections very quickly. Just some final thoughts. If not,
just one quick thing, if that's
please.
Okay. In terms of research management and administration, I just wanted to flag that the Association of Research Managers and Administration in the UK, ARMA, they are also piloting or starting a project where they would link up UK university professionals with African colleagues for exchange programs and shared learning. So that's another useful one for building these partnerships.
Yeah, I think UK research managers have a lot to learn from dealing with the practical day-to-day challenges of doing research in other parts of the world. And did I see, Kellen, did you want to say something just as we wrap up? Please, Kellen.
I just wanted to re-echo one very important aspect of partnership, and that's capacity building. I think all the way through a truly equitable partnership, capacity building is critical. And Pauline is mentioning it across, from research administration to, actual technical research implementation, but also financing. I think in our partnership with Noreen, we had wanted to bring to the UK the policymakers in tobacco control and HIV to sit around the table and we discuss, and we had included a session of having a policymaker in the UK to come and, speak, to these policymakers to share how are we doing things, how are we moving evidence into policies. So for me, I think that capacity building should be like a centerpiece of these partnerships. And so that we could avoid the syndromes of saying we are your saviors or your superior and so on, so that this capacity can actually build more and more strategic and important partnerships in research. Thank you, Chair.
Thanks, Kellen. Yes, and of course, lots of capacity here to be built from the experience of working with our African friends. I think we probably have to wrap up now. I'd just like to, on a personal note, say that, I found it really fascinating. I think the kinds of discussions we're having need to carry on and be applied to other areas of work, other geographical areas, but other sectors as well. Certainly in my role as a research champion, we're keen to explore how we can better build into the sort of the everyday practice from the earliest stage of designing research, commitments to decolonizing our research, to equitable partnerships, and to be held accountable. So there's a requirement for some evaluation of what we do, for our partners to evaluate what we do. And I think we need to explore some sort of more innovative and self-critical ways of operating. But it's also good to hear of the success stories and the more positive experiences that some of our friends have spoken of. So I would just like to sort of wrap up. I'd like to thank all of our speakers. I'm really sorry that we've had such limited time for each of the speakers, but I'm really grateful that we've managed to cram so much in to such a limited space of time. So thank you very much. I hope we're going to meet everybody again. I'd also like to thank Steph Richards, who's done the technical support and a lot of the administration and organizing for this event. I have to say, I've never stepped into a position like this and been so well briefed and prepared. So thanks very much, Steph. Thanks everybody and to all our participants. And I really look forward to continuing these conversations. Thank you.